Hey guys,
How's it going?
Hello, hello.
you're looking good, Dan.
Okay, I could say this. I'd like to say the same thing for you.
Well, don't lie. Although I gotta honest, I don't know quite what Leslie's doing up there. There's a rabbit or something staring at me. This is kind of freaking me out. Allie's got a new looking implant up there. I'm looking at some of the different things we got going. What we're going to do here is I'm going to start with just some simple, basic cases that I've been working on. Well, one simple and one not so simple, because I'm buying time for you, Dan, because there was a huge feedback on this because I didn't think they quite first got it when we sent out the invite. And then we sent that email afterwards. And I think that really explained things better. And since that's like, this is the first time too, I've had multiple people calling and saying, hey, I can't make it, but you really got to record these. These are all recorded and they're all put on the portal, FYI for everyone. And I think I'll send out an email tomorrow explaining that and showing how to do that. Carlos can make that. Carlos can make that happen. So to buy a few more minutes because there's still people signing in here, we'll go till about 7:30, and then I'll let you start in 8 minutes, Dan, if that's good for you.
No problem.
Okay, Carlos, we just click it over here.
Want me to share your screen?
Let me see. I do. Let me see. We got to get these out of the way.
How do I look at everybody on this thing, Mike?
Are
you on your phone?
you on
I'm
desktop?
iPad.
Okay. It might be a little different on your iPad, but at the top there should be a participants menu, or at the bottom that you can open up.
On the bottom bar.
Yeah, I see it. I just clicked on it. It gave me all your names, but oh, you know what? I can turn you on.
There should be a setting.
Yes, you can, Dan.
Oh, gosh, I shouldn't have said that.
Well, you went there. I couldn't help myself.
This one right here?
PowerPoint.
Okay.
Which should be right there.
I got it.
Okay, let's go to May 7th Study Club and from beginning.
Okay. And you have to click.
All right. Let's see. Slideshow from beginning. Is it showing?
Yes, sir.
All right. This is just a really simple case that I did today. As a matter of fact, it was a flapless case, and I didn't take any photos. Why am I showing this case? Because for those of you who aren't into the wonders of flapless, this was my fastest implant ever. It was 14 minutes. And mind you, the CBCT takes about 4 minutes to 5 minutes to get them over there and back. From them being numb to me touching them with a tissue punch, actually a perio probe, because I had to check the tissue first. So anyways, the first thing we have to have here, is the case. So here's the before and after. First thing you need is plenty of bone. Had plenty of bone. I'd grafted this patient from before. And they had about 3-4 millimeters of soft tissue, vertical height, connective tissue, and I had a world of it on even after this, I still had like 4 or 5 millimeters of attached gingiva down the buccal. So good tissue, good bone, and away we go. He's a Bruxen son of a gun. Oh my God, he's a Bruxer. I felt bad. I didn't have a 5.5 with a 4.3 core because even the 4.0 core I'm a little nervous about. So this is a 5 with a 4.0 core, and that's what it looked like. That's how well the graft had filled in there. It filled in very nicely. It had been like 5 or 6 months. And there's a side shot of the implant, maybe 1 millimeter too much to the mesial, but pretty good other than that. For those of you who aren't doing the exploring the wonders of flapless, when you can do it, again, only when you can do it, man, you're missing out. This guy was in out 14 minutes. He looked at us and goes, that was it? I go, yeah, that's it. And I got to work on packing for Mexico, which is going to be a son of a gun for this trip. So I got an extra 45 minutes in my day. That's lovely. That's a real easy case. I just wanted to show you this for those of you who aren't doing flapless. This guy came in a couple of years ago, 18 months ago, and we're just now finishing him up, and you will see why. So I'm thinking this is going to be an AID case. This is good. The guy's got a bit of a mess here. He's badly broken down. You can see this. But I'm electing to save teeth whenever I can. So we start to fix things up. And I put in the 2 implants up top. I'm going to have 2 implants on the upper left. and I'm at 4 on the bottom. And we're doing good. You can see that I've crowned that one tooth was broken down, did a filling on the other one. We saved those. Let me go back to the other one. Sorry. We just did some simple fillings on these for now to buy us time because we were putting these in and then we're going to restore those afterwards, which you'll see at the end. All right, so I did all 6 implants in the same sitting, and I'm thinking that this is great, but I knew I had problems here. So first off, you can see the exostosis, so we have a ton of bone. That's not an issue. But what you don't see here is that the mandibular bone is D1 bone. And also, if you're looking at this tissue is not real thick, especially when you're going over the exostoses and all that. It wouldn't have been a bad idea to cut these out and maybe try and get a better blood supply that way, but he wasn't about me cutting his half of his bone off. So I placed the 6 implants, and this is what happens to that one. I go to look at it, and you can see that tissue pulling on there, and I've got a couple threads showing, and that is not going to be a winner in my book. So I tried grafting, which I never do, but I thought, my gosh, it looks so good. The case would be so good if I could just push that tissue together and slice and dice and sushi it up. And then I did, after the fact, I did a vestibuloplasty to try and free up that tissue a little bit more, to try and keep the muscles from pulling on that so it wouldn't have that problem. And then I expose it and I say, well, I'm going to try and put the tissue on there. And the bottom line, after I did all of that, I had to admit that this thing just wasn't working. So I did what I always do. I took the damn thing out. So I've taken it out. I've got a defect like this. I've already grafted it once. It's still not looking great. It actually does heal in better than that after the graft. This is between the graft. So my question to all of you is, now what are you going to do in your office? You're start off a house of fire. Life is good. You got the crown bridge. The guy will let you do whatever you want. He's a fantastic patient as far as that goes. No patient management problems. You've already tried grafting this thing and it's still not working. The blood supply, the tissue looks thin there. What are our options on a case like this? Any suggestions from the peanut gallery?
Yeah, I do.
Do it, Dan.
Yeah, I love taking tori out. In this case, I would tell this guy, hey, really sorry, but we have to take this tori because we're going to use it to graft this site that's failing. An autogenous bone, your own bone, is going to work the best. So I'd start there.
I think that's a great solution. Let's say, because this is what he did say, that he's not in for that. So if you can't do that, which is a great solution, by the way, because you're right, it's autogenous bone and hell, his life's gonna be so much better if you take any one of these things and grind him off of there, so you can have some space for his tongue, God forbid, in the floor of his mouth. And it's not a difficult procedure, so it's easy enough to do. But he has said no. So what is your other option here? And it doesn't just have to be Dan. Anybody can chime in on this. Allie, Wing, anybody?
Could you put the implant in closer to tooth number 30 and just cantilever something?
That is exactly what I did. Because I saw this bone back here and I saw a complete mess up here. I thought about putting it over here, kind of more toward the tuberosity side and kind of doing a bastardized sort of thing. And the more I looked at it, the more I thought, because these are huge implants I can put here because I've got a world of bones. So it's not a question of some small implants. So unfortunately, I didn't take pictures of that surgery, but I will show you the final restoration. So here he is now with the crowns on and all that. And here's, can you see the arrow on there on your screen?
Yes, sir.
Okay.
On the right, as long as you.
So, wait, I'm sorry.
As long as you keep it on this screen.
Yeah. Okay. Good. All right. So here it is. This is exactly what I did. This is a cantilever here. This is orthoponic. This I put another implant down here. Unfortunately, I didn't show you that in the surgery, but I'll show you that in the X-rays. This is the other side that went perfectly. 2 up top, 2 in the bottom. I had no problems with that.
What kind of abutments did you use for 30 and 29?
What kind of abutments? Big, strong ones. What do you mean? What kind of abutments?
Well, were they custom abutments or was it?
Yeah, everything's custom abutment. These are from Danny's lab in New Orleans. So, yeah, they're all custom abutments, but they're OEM parts. So it's all Megagen parts. So I can take these things on and off. Let's see here. All right, so let's look at the x-rays. So this is when he first came in, the root tips, the bad decay, this, that, the other thing. He's all broken down. He's had an implant before, so he's implant savvy. And I'm going to clean this out of here. I'm going to put one here, one here, one here, one here, one here, and one here. I'm using this virgin bone here, thinking, hey, this is okay, because that's as far back as his occlusion goes. And that's the middle ground when the one implant had failed. So I got this one. I did a little a crestal sinus lift up there that lifted, put and there's actually a little spiculum bone sticking up there that I actually used that to aim at to kind of reinforce it. And it actually worked out very well. That's why they're a little bit closer, because I was trying to aim into that one. These here. So this is the middle ground. And that's exactly what I did. You can see that this has been grafted now, that the graft, it worked as far as there not being a defect there. So there's not some god awful defect if you went back and looked at those pictures. But I did exactly that. And I pushed it forward as far as I could in order to make the cantilever as small as possible. So that's why it's a little bit further forward. But that is my, I'm gonna try and slide this thing around. Sorry, I've got my picture all over my, yeah. Up there is the crestal. So it turned out to be great for this guy, because I mean, he doesn't care if it's a cantilever or not a cantilever. But I took the path of least resistance, which is what I often do in implantology. I don't try and make my life more difficult than it has to be. So if you go back to here, that's what it looks like with that in there. Any questions? All righty. All right, Dan, I've killed my time as much as I can. Carlos, I think that's as far as we're going to go as far as signing people up. They can join as they come along, but I think I'm going to let Dan start now.
Okay.
Ready?
All right, Carlos is going to help you get to your room and all this stuff.
All right, Carlos, what do I do?
Okay. Do you see an option there to share your screen?
In mine, it's a green arrow on the bottom bar.
I do not. Oh, stop videos, participants, share. There it is, share. What do you want now?
Give them 2
Okay.
seconds.
So once you can hit share your screen, and then you can hover over your presentation.
It just gives me a lot of,
Different screens.
yeah, a bunch of words: whiteboard, bookmark, website, URL, box, Google
Okay,
Drive.
you might have to switch over to a computer to actually present your case. Sorry about that.
Well, we learn by doing.
Is there questions in the chat?
1 second. Is that better?
Yeah.
Okay.
Let's go to the chat. We'll check some questions in the chat and see if there's anything there.
No, sir.
I'll let
Okay,
Sharon
we're
and I
good.
got it together.
Let me see.
Dan, you will have to log in to your Zoom account from your computer and leave the call and then rejoin.
Okay. Dang, that's too bad.
That's all right. I'll buy time for you. Okay, let's see what I did to this fella. Are we sharing screen?
No, sir.
Go ahead. All right, this could be a little on the raw side because I'm just gonna go through my pictures. But we're placing an implant in a, oh. You can see it now?
Yes, sir.
Okay. We've got a sinus, it's actually a Presto sinus lift. I'm doing this guy. It's not moving.
You only opened one photo.
Let's close that out. That won't, here it is.
1 second.
Okay, so once again, I'm being lazy. I'm going flapless whenever I can. Obviously, this patient has good tissue. So when I do this, so I've got the Versa burp in here. I'm gonna go these photos pretty quick. We were trying to find one where we could actually see down in there. We were trying to use different techniques of shining the light in there. There you go. That you can see that we it just pushed right up to the membrane without perfing. That's just a little bit of bone right over the membrane that's left on there. And I'm trying to use my Zerk mirror because I figure that's going to be as bright as anything, and I only want a small field anyhow. Don't know if that's right or wrong, but that's what I'm doing there. I'll click through these because it's going to be the same shot over and over as we're trying to get these. This is the Plasma X, which looks too cool for words. I can't tell you yet if it makes a difference. The research says that it does because I've only had it for 2 months, so I can't tell you that I've done 100 of these and 99 of them have all that. But I'll tell you this: there's not a patient that I've had that doesn't love staring at this. It's mesmerizing for them. And you just take the shaft, you drop it in there. I use the longer one so you can grab it out without touching the implant, and then I use the long driver. So this was us using Versa burrs up in there before that. I'm showing the time to show that this thing took about 20 minutes or something like that. Again, flapless is just the way to go. That's a little piece of tissue we have left. That's the tissue plug. I'm showing that's how you get these things out of here. Is when you do the tissue plug, you just go straight down, scoop underneath to the bone. And you can also do a little indent in there to show that. But I mean, you guys have all seen my videos, so you've seen that. This is just showing you that I actually do what I do. So this is the beginning of the case, me mapping out where it's going to be. It was going to be right here. So I had enough tissue over there. That's the nice thing about the indent is you can sit there and measure the tissue all around it. Sorry, this is the backwards progression of this. Let me see. I will do this real quick. Patel. 696. Will Dan get set up?
What are you trying to do?
And I believe this is the last one where it's inserted. So you can see I think we just did a sinus bump on this. I'm not sure that we did a lift or not. We'll find out in 2 seconds. All right, so there I am.
You would have to do that.
Yeah, that's more of a bump. Right there. Let me upsize that for you. It's one of my favorite tricks. If I go a little bit off center, I can get a little bit more bone there. And I'm actually trying to angle this thing out to the buccal. You can see I've got a ton of bone, had plenty of soft tissue. That's just a case that we did yesterday. The latest thing that they're talking about the circuit is show the last 5 case you did. So that's a sinus bump I did. Dan, how you coming there?
We're good on it. Okay, give me 1 second. Are you helping Dan? Huh? I'm helping both.
Okay, go
What
ahead.
do you want to do?
I'm just killing time for him.
Okay.
So I'm ready whenever he is ready.
Okay.
I'm just picking cases that I know that I've done recently.
Somehow get to your email on one of these computers.
He's sending, Carlos is sending him a link to hook up here.
And you will have to create.
Let's go backwards off of Harsh. Let's see what else we have here.
Hey, Mike.
Yep, you ready?
No, it's Rabideau. I got a question for you.
Yep.
Couple, yeah, maybe last study club, you talked about some different newly available megagens that had a little different top on them
Yeah.
that you.
They're
Yeah.
the 7 mm ones, and they're actually they call them 5 mm because the last 2 mm are machine polished. And the idea is for when you've got these short areas where you just know you're not going to get under the bone all the way, or heck, it might be sticking up a little bit. You've got a 2 mm cushion in there basically. Now, obviously, they have limited usages because you're only getting 5 mm of thread on them. So I use them always together in the posterior, and I split across them. Is all my uses of them so far. I think I might have done one premolar with it or something like that. But I just love the idea of. I think that all Megagen. I wish they'd all go like this. Get rid of that last thread that's so small it doesn't work, and put like a 1 mm collar up there. I would love to have a grace between these. So, and again, I've only started using these. Apparently, they had them in Korea for a while, but they just brought them over here to the U.S. about, I don't know, 6-8 months ago. So I've been using them for about 4 or 5 months. So I can't tell you that I've had great long-term results in certain cases, but I can tell you all the surgeries I've done with them. It just heals around them just great. And I showed that last time that I saved a couple cases that where I had done ridge splits. The bone had died back a little bit, and the implants had failed. And then I put those in there because in dying back, that it also increased the soft tissue, which was, I think, the problem initially. Because these are old cases I was doing before zero bone loss concept, and it turned out pretty nice.
Are those available, and how small
Oh,
a
sure.
diameter can you get them?
They're 3.5, 4, 4.5, 5, I think. Are all the choices that I could think of off the top of my head. I know 3.5, I know 4, I know 4.5, I know 5. I think maybe 5.5. I think they have, and you have to call them a 4.5 by 5, or on the box it says special. So I just talk to Joel or to Lana, his assistant, and tell him what I want specifically, and that's how I morph this out. But you can definitely get those. And I would have some of those in your armamentarium because there's going to be a time where that 7's not going to quite fit for you. And that machine finished, it's not polished, which Joel says, if it's polished, it's too smooth and the tissue won't attach to it. When it's machine finished, it looks polished to the naked eye, but it's got smaller grooves and scratches in it, so the tissue likes adhering to that better. Is the best way that I can explain it to you, because I mean, all this polishing is just different size scratches. You all know that. So it looks polished and shiny, but it's not. It's machine finished.
Yeah, great. I've got one of those coming up, and I wanted to know how to get those.
You just got to order them.
Okay.
Okay. Can you guys see this case up here, the teeth? I'm trying to buy Dan some more time. This is another case I did recently. Was that an immediate? Are you ready to go?
No, but they're not seeing your screen.
Okay. Let's see what we did on this one. Is this an immediate? No. I'm thinking this is the second phase of it. That's the crown. When we posted off Final Press. Yeah, it was an immediate that we did. So that's how I suture my immediates. Oh, this one. That's right. All right, you know, we all have, we have our own lab now. So what we did on this one is we opened up for second phase surgery. And what we did was we put in there PMMA tooth. It's completely PMMA because we didn't have the time to get a scan body. So even the part that fits down in the implant is PMMA. So we opened it up and we put it in there to try and form the tissue, and it worked out pretty nicely. So we opened it up for second phase surgery. Put the this is something Corey Glenn told me that he used to do is he'd take an impression the day he places implants, he buries all of them, and then when he does second phase, he opens them up and he puts the final restoration right in there and lets the tissue form around it, and then the tissue fills in all the gaps and all that. You don't have to worry about, you know, zero bone loss concept and saving the shape and doing this and doing that. So I thought, well, I don't know if I could jump all the way in the deep end. So that's why we made this so far out of occlusion here, was because we didn't want her biting on it and breaking it. But what all I'm trying to do here is form the tissue. So this goes from, I wish I'd taken a photo of it before. Dadgummit. Yeah, there you go. So it's just flat tissue right there. As you can see, the little percolator hole that comes in over these implants when they're pushing the bone out. So there's no papilla here at all when we start with this. So we did that scan 3 months ago, and we put the temporary in there, and that's what the tissue looks like after, I want to say it's 3 weeks. Let me see if I have the dates on these. There. We didn't wait long. That's why the tissue looks immature like that, because we figured we could, once it started to form nicely, we said, well, hell, it can form around the final restoration the way Corey was doing it. Now that I saw that it's actually going to work. So I used a nice temporary, and I would recommend using a tie base. We just didn't have ones. That's why I put it so far out of occlusion. Like I said, you can see how that tissue is really immature in there and still healing. Let's see if we have the final in here then. There's the final right there. Oh, come on. Okay. I'll get a close up in here somewhere. So there's my papilla forming around there. These are, like I said, these are ongoing cases, so I'm not even sure if I have the final on this one. Ah, there we go. At least the 1 week for the suture being out. So the tissue is definitely filling in there and forming papilla. And there's the little temporary tooth that Isaac made for me. This is his fine lab work, and we were both a little leery of that. That's why we took it out of occlusion. There you go. So that's just a really nice PMMA temporary. So it's a cool way of making second phase. Oh, I didn't realize I had pictures from the surgery. There we go. We did a tall cover screw to grow some extra tissue, and that's just with the Pathfinder there. So you can see that the position's pretty good. There it is, covered up.
Hello, I'm on.
Okay, very good. All right. Any questions about that before I go off of that?
It says share screen down there. So as soon as he's done, I'll hit share screen.
Okay. Ooh, can you see message recording? All right.
Okay.
I'm gonna stop sharing
Most of
here.
mine is just verbal. I got a couple pictures, but
Okay. Okay. You can hit share screen on yours, Dan, I think.
I'm ready to go.
Okay, hit it.
Doing the share screen thing.
You got 2 people on the way.
Everybody hear me okay?
We hear you just fine. And I see you. And I see you staring back at the screen. I can see it in your glasses. We just got to get it up on the screen. Carlos is here.
A lot of mine is just verbal.
Where he is
What's that?
trying to share. needs to hit the window that he's trying to share.
Tell him that.
Okay.
Oh, you
can't
did
hear me?
this?
Yeah.
I heard him.
You see that hit share screen and then
Yeah, I did.
it'll
I
get,
did.
okay.
What a pain. Sorry, guys.
No, you're okay. Okay, after you double click, did you hit share at the bottom right?
I did.
Okay, we should be able to see.
Bottom right? Oh, no, not bottom right.
Yes, sir. So you click on,
Oh, wait a minute.
there we go. Nice.
Hey.
So we're seeing your Zoom browser right now. If you switch over to your presentation, we will be ready to go.
Tell him how to switch over. You to click on it or something?
Yeah, you have to click on your presentation. I'm not sure where you have it on the computer.
Well, we've lost so much time already. A lot of mine is just verbal. I have some photos. I could actually put them up on my phone, but that's too bad.
Okay, but yeah, you can just start talking if you would
All right.
prefer it that way.
Hey, everybody. So a lot of this is just going to be a paradigm shift in the way you think about anesthesia. I've been in practice for 46 years, 27 of those as a sedation dentist. And doing the sedation has really formulated in my mind the way that I go about anesthesia. First, I got to tell you that these are my preferences. You may have a better way to do it, but this is what works better in my hands. I have 3 other doctors that work for me and 35 staff. 7 or 8 of those are hygienists that we've taught this same protocol so that we all have the understanding when a procedure is going to take place, how we're going to go about anesthetizing that. So that being said, I'm going to ask you, and you can answer to yourself. Do you ever work on people that you don't have 100% numb and you can't figure out how to get them numb? Do you have to work in a bloody field? Do you ever run out of anesthesia in the middle of a procedure? I know all you guys have run into this many times because we all do. So the first thing I'm going to suggest is that you consider the paradigm shift I'm asking you to do, and that is to get out of the lidocaine / infiltration philosophy. We were all taught about using limited anesthesia. That's from the lidocaine days, okay? Because we're worried about cramming too much anesthetic into the liver and it not being able to process it, okay? That's where that comes from. Lidocaine's an amide, and we get amide types of metabolites with it. So the other thing is the infiltration thing. Because we were taught to use limited anesthetic, we really weren't taught about duration through saturation. So I'm going to go over those things right now. The preferred anesthetic in your armamentarium for anesthesia should be Articaine. It's the only anesthetic that's been produced specifically for dentistry. Malamud, in his new book, the 7th edition, I would suggest that you all get it and read it because things are different. He dedicates 4 pages in chapter 20, the first 4 pages, to Articaine. The most important thing we need to understand about Articaine is that it's not metabolized in the liver. Does anybody know where it's metabolized? Nobody? It's not in the liver.
Blood.
It's in the blood, correct. It's in the blood. Well, how in the heck did that happen? Well, Articaine has a thiopene ring replacing the benzene ring. So it acts in a metabolite way as an ester, not as an amide. 90% of it is metabolized in the blood, which is a huge deal. The half-life of it too in the blood is like a half of lidocaine. So me being a sedation dentist, I'm already concerned about what my drugs, my Versed, my fentanyl, is doing to the liver. How much more can I pile on? So for me, Articaine has, as soon as it came out, I knew how it must hit metabolized, I started using Articaine. Also, interestingly enough, there's never been a known OD to Articaine. So talking about ODs, the common formula for an OD with anesthesia, local anesthesia, is a young kid who is very well behaved, needs a lot of dentistry, and a brand new grad who needs to do a lot of dentistry. That is the formula for almost all the ODs that take place. Well, now the pedo guys don't have to worry a whole lot about that because of the way articaine is metabolized. Not only that, when you read through those 4 pages that Malamed talks about, the way that this is metabolized, it also perfuses through bone better. It's 1.5 times more potent than lidocaine. It metabolizes through the bone better. It metabolizes through the soft tissue better, through nerves better. It's all pluses. It's all arrows in the direction of success. So that being said, I think about anesthesia maybe a little bit differently because I'm a sedation guy and most of my patients are sedated for 2 or 3 hours. So I need anesthesia that's going to last a long time. So what I like to do is I like to pile it on. I talk about it anesthetizing with a shotgun, not a dart. So let's say we're going to do, I'll give you an example. I'm going to extract number 1. I'm going to do an endocore crown on number 3. I'm going to do a couple of restorations on 4 and 5. Here's how I would anesthetize that. I do a PSA, an MSA, and an anterior middle superior alveolar, and a lingual infiltration on the molar. I'm doing the endo on. Everybody got that? Is that the way you would go thinking about that? Or do you think about infiltration number 3? And I'll go back and infiltrating number 1. I'm going to infiltrate 4 and 5 minutes, maybe split a carpio between those 2. You don't have to do all that. Let's say you're going to go a little bit farther forward. You're going to do that same group of treatment, but now you're going to work on numbers 6 and 7 also. So you would pile on an ASA on that too, right? So if you did the ASA, you already got the anterior middle superior alveolar, which is basically a lingual ASA, and I'm going really fast, but it's a lingual ASA. So you can do all that treatment and it's going to last for a couple hours. I'm going to do the endo first, right? Actually, I'd probably do the fills in the anterior first, then do the endo, core crown, and then take out number 1. Let me give you another, for instance. Let's say you're going to work between numbers 6 and 11, and you're going to do either implants or grafting, whatever you want to do. You're going to do 2 bilateral ASAs, and then the anterior middle superior alveolar. Is anybody at all familiar with that guy, that injection site?
No.
Okay, it's new. That's why I want you to read the book. I don't know if I'll be able to show this, but I'll try to show this photo. It's relatively new. The interesting thing is, like I mentioned, it's literally an ASA that you're doing from the lingual and simply saturating better. And you'll be able to work on anything you want to do between 6 and 11 all day long.
Dan,
Go
if
ahead.
you'd like to text the photo too early, I can share the screen on my end and pull up the photo.
Okay, that would be awesome. Come on.
For the rest of the group, while we're doing this, Dan and I are going to get together on this, and we're going to figure out the PowerPoint that he was going to present, and some of the other things he's referencing. Because Dan, I can tell you for the whole group, having taught all these folks and not knowing a damn thing about what you're talking about right now either, because we're all doing infiltration. I mean, you're exactly right. That's what we were taught because we were all taught, at least I'm speaking for I guarantee 95% of us at least. So we need to see where these nerves are and where we shoot at exactly. So you and I are going to come up with a PowerPoint that we can put on the portal with you voicing over, which is a real easy thing to do. That's how I have all those recordings on there. You just basically sit there and go through your own PowerPoint and you talk to yourself, say, oh, I would do this, and you can show all these photos because I need to see where the ASA is because as I sit here right now, I do not know that. And I bet they don't either.
I'm sending these photos.
We'll
Should
use the
be good, man.
photos, but we're gonna have something also, just telling the rest of the group, because as they're sitting there listening to this, they're thinking, man, I'm never gonna remember that. Cool. We're gonna have a reference for all of this always. And I appreciate you saying read the book. I also know my audience. I don't think most people are gonna read the entire book to find out where the ASA is. You're gonna help us to do this faster. And then we can read the book once we're properly enticed into that.
Okay, how much more time do I have?
You have as much as you want.
All
Because
right.
I already did that, and we've got some other stuff here. You've got probably another hour if you want it.
Okay. Uh, does anybody have any questions so far? No. Okay. I sent those. There you go. So what you're looking at is the plexus of nerves that are actually, what they've done here is they've carved off some of the maxilla on the inside of the, like lingual to number 5 and 6. And what
Hold
you're
on
looking
for, Dan, hold on for 1 second. I want to make sure that everyone else can pull up the picture and all that. Or are they seeing it on my screen
It
now?
should be the main screen.
All right, so you have it, is it on the main screen now?
Yes.
Okay, cool, very good. Sorry, go ahead, Dan.
Okay, so what you're looking at is this plexus
Mm-hmm.
that exists lingual to the apices of number 6. And it's lingual to number 5 also, but it's a big plexus right there.
Mm-hmm.
Did you get that other photo of the
Yes.
actual injection spot of the
Yes,
ASA?
sir. Ready to switch over?
He's moving over to that now, Dan.
Okay, I'm gonna send you another one. I'm not sure that you got this one.
This is all the stuff we're gonna put in the PowerPoint, and we'll put little notes on the PowerPoint saying, here's the injection site, here's this ASA, da, 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 da. We'll map this all out for everybody.
So what you're looking at is a portion of the dental plexus. I sent another picture we'll go to in a minute. But the idea that that these are actually blocks, I don't think exists in our mind. We think of infiltrating, but in reality, they're what we call field blocks. They are blocks if you get in the right spot. So you can see in that dental plexus, you can see where the middle superior alveolar nerve is, the posterior superior alveolar nerve is, the anterior superior nerve. What you don't see on this is the plexus that's behind the anterior superior alveolar nerve plexus. That's kind of part of it right there. But let's talk about this for a second. Let's say you're going to take out number 16 here. You're going to do an endo on number 3 or sorry, 14. Restorations on 4 and 5. If you do a PSA, and I don't do a PSA like we were taught to, I sneak it up on the distal of the 3rd molar and I don't go any higher than maybe the end of my 27 yellow, 1.5 inches. I don't go much higher than maybe the apices of the 3rd molar because you don't have to. I'm not going to get involved in that pterygoid plexus of veins up there. You guys all remember that? Don't go there, don't go there. The MSA then is at the 1st molar, the mesial root, and the bicuspids. That's what the MSA covers. The PSA covers the 2nd molar and the 3rd molar and the distal root of the 1st molar. So that's pretty simple to get at. The ASA, so interestingly enough, we don't remember that. Most of us don't remember that. If you do an MSA on the 1st molar at the mesial root, that'll also cover the 2 bicuspids. But what I like to do with that is I like to do the anterior middle superior alveolar 2 because it doubles my anesthetic to the bicuspids and actually farther forward. So can we go to that film of the palate? You have a picture of the palate right there somewhere.
1 second.
He's finding it. Carlos, first would like to know what a palate is.
I learned that much. I'll pick up a little bit and listen to you guys.
So Dan, I'll ask questions as we're going along here. So these are all palatal approaches for these things?
No, they're all buccal. The only palatal approach that you're gonna have is this anterior superior alveolar. That,
Okay.
that ring right there is showing you where the injection site is for the anterior middle superior alveolar. Now, we're gonna talk about this one for a minute because it's extremely valuable for people who are doing aesthetic dentistry. And you want them to be able to lift their lip. If you do bilateral anterior middle superior alveolars, like what you're looking at, it's basically at the, if you can imagine where the root tip is on the lingual, and then where that center suture is, if you divide that, go right in between the two, that's where the injection point is. You'll only see the orifice about 25% of the time. The rest of the time, what is beneath there is that plexus that we're talking about of nerves that goes towards the anterior. So if you do bilateral anterior superior alveolars, you're going to get all of the pulpal anesthesia bicuspid forward. All those teeth forward have pulpal anesthesia. If you only do those two, they can still lift their lip. It does not include the soft tissue on the buccolabial side. So it's a beauty if you want to do aesthetics, you want them to lift their lip up somewhere along the line.
So
Now,
do you numb up the facial before you pack the cord after you're done, say prep, doing 6 crown preps up there or something?
if you're going to do crown preps, just go ahead and do 2 ASAs on the buccal labial
Mhm.
and be done with it. Do 2 AMSAs like this, and then ASA on both sides, and they'll be numb for days. That's the beauty of that anterior middle superior alveolar on the palatal aspect. If you're doing implant, if you're doing grafting up there, implants, it's going to take you 2.5 hours. You got to do bilateral ASAs, bilateral anterior middle superior alveolars, and you are off to the races. You won't have
And
to.
to be,
Go ahead.
to be clear, this is the MSA we're staring at right here.
Anterior middle superior alveolar, yes.
Oh, this is the anterior, so this is the ASA.
Anterior middle superior alveolar.
Oh, okay, okay, okay.
The ASA is on the labial of the cuspid at the root tip of the cuspid.
Okay.
You're doubling up the anesthesia to all those anterior teeth by using this palatal approach. It's a lingual ASA,
Mhm.
except you're including the bicuspids. It is I use this son of a gun all the time now. And it's new to me probably about the last 6 years when this edition came out. So it's a really worthwhile thing to understand. We all know about doing endos and taking teeth out. You got to do a lingual infiltration. Does everybody know that? You got to do a lingual infiltration of the palatal root. Yes? No?
Sorry.
Yes.
We all know that, right? You're doing anything on a maxillary molar, always do like a third or a quarter of a carpule at the root tip where you think the root tip is on the palate. You have to anesthetize that palatal root somehow, some way, and you're not going to get it from the buccal all the time. Rarely.
There is a
Because you got
question
that
from
sinus in
Amy
the way.
Bender. If you could open up the chat.
Hold on, Dan. There's a question in the chat.
All the way to the bottom.
Okay.
Amy Bender.
No issue with cardiac on the palatal side of the tissue?
Say that again.
The question is, and you can see it on the screen, you should be able to, so no issue with articaine on palatal side issue.
No, why would it have it? Why would it have it? I'm going to ask the question back. What in your head is making you ask that question? The epi?
I think, Dan, that personally speaking, and I dove in with articaine too, because it didn't make any damn sense to me. Numb is numb, and I didn't give a damn. But people were worried about pedo. People were worried about necrosis. It's just too strong. It does this, it does that. And what you're saying in this is all that has been debunked. That there is no real danger with articaine. Correct?
It is 0.6 the toxicity of lidocaine. So now why are you going to use lidocaine? I know I'm being a smart aleck here, but that's all been debunked. It has less toxicity than xylocaine, lidocaine. The most toxic one is actually prilocaine. So yes, you should use articaine everywhere. But I think we all know, and if I know I haven't said this, never use 1 to 50 epi on the palate. You'll get dehiscence, man. You can use it regionally, like around the molar, in the attached gingiva where you're going to be doing some incisions or whatever, but don't do the greater palatine block. Don't do an AMSA with it. Don't do a nasopalatine with it.
Interesting. It would never ever occurred to me, but I hadn't heard that before, but I've never done it because it just wouldn't occur to me to use that.
I had a friend that had the whole palate dehiss because he did bilateral greater palatine blocks with 1 to 50 lidocaine.
And why did it hiss? Because it shuts down the blood supply so much, the tissue necrosis?
Exactly.
Hmm.
So the discussion around this AMSA, I'm glad we had the time to talk about this because I'm telling you, it'll change the way that you go about your day. When I go and sit down to do a procedure, they're sedated, of course, but I'm done with anesthetic in 5 minutes because I'm not running around doing all the infiltration stuff. The only time I would ever infiltrate is if, let's say, I'm going to take some lidocaine 1 to 50, and I'm just going to infiltrate around where I'm going to do my incisions. That's it. But the rest of the time, I rely on this kind of mentality, getting away from the infiltration thing. We haven't talked about the mandible yet. This is a little bit more, the palate's a little bit more thoughtful. But since we're thinking about the mandible, let's talk about the mandible. Because you guys will be uncomfortable with this, I know you will. If you don't know how to use, or if you don't know how to do a gout gates, you need to learn how to do it because the gout gates is going to be successful 95% of the time. If you want to hit
Okay.
100, go ahead.
All right. I'm going to speak for the group here because I want to hear all that in a second. Take me through the maxilla a little bit more here. I see these here, and maybe it's hard because we can't get the photos up here. Can we get those photos? Do we have in there? Can we
Well, I got another one looking at the maxilla from the right side. So you're looking at like 1, 2, 3, 4, 5, 6.
Anything you sends over, I can put up.
Okay, so if you send it over, Carlos says he can put it up there. Because I want to get through this first before we get into the manual. And again, I can't stress this enough to the group. I get it that this is sketchy right now because hey, pass this over and pass this. This is too important. Dan, I think this is huge because you're doing stuff that I am not doing. And I'm telling you, I'm fighting, particularly in the maxilla like a mother. With the mandible, I can do a septicane block, throw a marcaine on top of it. And that's going to take me through damn near any surgery that I need to do. Not that I don't want to learn the other stuff. I absolutely do, but it's the maxilla that flummoxes us. And if you're saying that you can block these for full mouth surgeries, and in my case, full mouth might be 6 minutes. Maybe someone else who's slower, full mouth is maybe just 2 implants, but it's taking that long or something like that. We really need to understand the blocking mechanisms that you're using in the maxilla.
Okay, so you can put that picture up of the maxilla. We had it up before.
Okay.
Let's talk about doing an all on X of the maxilla.
Exactly.
All right,
Carlos?
there you go. Well, the one before this.
Okay.
Well, let's start with this one since it's up. What would you block here? So you're doing a full arch. What would you block here?
Okay, using articaine, I would do a greater palatine block. I would do the anterior superior alveolar where that circle is.
Mm-hmm.
I would do, you don't need to do a nasopalatine because the AMSA takes care of that. So from the palatal standpoint, I would probably do like a quarter carpule at the apices of the second and first molars. I'm going to double up on what I'm going to do on the buccal. Okay, now we're on the buccal. We're still doing all on X, so let's talk about this.
Okay.
I'm going to start from, I always start from the back.
Mm-hmm.
So I do a posterior superior alveolar. Everybody know where that is? It's going to be basically at the apices of the third molar. Even if the third molar isn't there, you're going to do a block there. So you're going to do a posterior superior alveolar. You're going to put a whole carpule there and make sure you get it up there. A lot of people don't get it up superiorly enough.
So you're using a short needle through the apices, through the vestibule, all the way up in the third molar, because that's I was taught the 45-degree from the anterior shooting back toward the zygoma and all
Right.
that. You're saying it's easier, which makes sense to me, to go through the vestibule of the third molar up what the full length of a blue needle?
I don't ever use blue needles. I use yellows.
Okay.
I
All
use the
right, good
long
for
ones.
you. Yeah, I'm a big fan of the yellow ones too.
Yep.
Okay, so how much are you using, how far up are you going with that? The full length?
No, it'd probably be about 3/4 of the length of the long to the 27 long. So think of the apices of the third molar. That's the only place you got to put it. Think in your
Mhm.
head, the
Got
apices
it.
of the third molar. Dump a whole
Got
carpule
it.
there. You're going to go to the first molar, and you're going to dump a whole carpule there.
Okay.
Okay. You're going to go then to do the ASA, and dump a whole carpule there.
And where do we shoot? How do we shoot that one?
ASA is at the root tip of the cuspid.
Okay, so you're going three places. You're going third molar, first molar, cuspid, all the way 3/4 of the way up with the long needle, and giving a carpule in each one of those areas. So
Correct.
that's 3 carpules on this side, 3 carpules on the other side. If I remember correctly, it's a carpule or so in the palate.
That's
Because
about it.
there's, or maybe 1.5, 2.
Yeah, maybe 2.
So we're up to 3, 6, 7, 8. I'm going to ask the question so people are ready to ask already. So did I just overdose my patient? And I know what you said earlier. I want you to reiterate that again so everyone hears this, because that's the question in their mind right now, because it got hammered into our minds growing up.
Right. What got hammered into your mind though was lidocaine.
Right.
We're not using lidocaine anymore. This is that lidocaine's metabolized totally in the liver. And again, this came out of my training as a sedation dentist.
Mhm.
I had a pussyfoot back then. Okay, but if you're going to do full mouth extractions, which I do all the time, I'm always taking out 15, 18, 20 teeth. I mean, I do that every week. You get tired of things not being anesthetized. So when articaine stepped into the picture, I examined it immediately. And I went to saw Malamed when it first came out. I mean, I physically sat in front of him and listened to him talk about it. And so I was a fan. And so I've never, ever had an issue, but you don't need to listen to me. I mean, there's been 6 million, 600 million, a lot of carpules every year that are using articaine. And there's no known OD to it. Nobody's ever OD'd on it. Because it's metabolized totally in the blood. It's metabolized like an ester. And so everybody, you don't have to believe me. Get the book and read it.
Oh, Dan, we're going to believe you because you do this all the time. Dan's done so much of this that the people that taught him now are asking him to teach other people. So he's teaching sedation on us, and what you're doing here is really cool. So is there any limit? So I've just put in 8 carpules. The patient's not numb. In my world, before this, I would have put some Marcaine on top of that for longer lasting and to hit it a different way. You're saying no, because that's metabolized the old-fashioned way. It was made for medical, not dental. So you're saying hit it with a little more articaine?
Well, I'm faster than you anyhow.
Yeah, probably so.
I'm saying you in the maxilla, it's not going to help a whole lot. I've never found articaine to help a whole lot. Double up on your articaine. If you know it's going to be a really long case, just double up on your articaine. So let's talk
Okay.
about that. Let's talk about that for a minute. Anesthesia requires saturation of that axon, correct? So they keep it saturated, keep a lot more anesthetic in that neighborhood longer. It's easy. Now I'm rattling the cages of the people who are worried about the volume too.
Right, exactly.
So you just got to get over it. It's a paradigm shift. That's why I started the discussion with it. It's a paradigm shift.
Let's back up through the chat here a little bit. He's saying, Robert's saying, can you see this on the screen, Dan?
No,
The
he has
chat-
to hit the chat.
No, my computer doesn't work like my iPad does. But anyhow,
That's okay. I'll read them to you. I know
Okay.
an oral surgeon that has given up up to 28 carpules of septo, but I don't know how I feel about putting that in the note.
well,
Dan, what's your septo limit?
there is none. So let me go back to my sedation training.
Okay.
When I sedate somebody, I never know how they're gonna react to my drugs, so I titrate to effect. Okay, so I put on some, my first drug is always fentanyl because I want the analgesia so that when I do my injections, I don't disturb their sedation. And then I start trickling on Versed after that. You really don't know how much this patient is going to use. There's the blood-brain barrier. Can't measure that. You can't measure albumin binding, and you cannot measure metabolic rate. So I've gotten, after I've done a couple thousand sedations, I could tell by looking at the person, give me a pretty good idea about how much I'm going to use. Let me explain. When I have a 17-year-old kid come in, and it's a guy, and he's got veins sticking out of his arms, and he's about 135 pounds, but he's ripped, I know I'm going to dump a gallon of drug in that guy. So a lot of people would ask me, well, what's your maximum dose of Versed? What's your maximum dose of fentanyl? Oh my gosh. Well, my maximum dose of fentanyl I've ever used is 525 micrograms of fentanyl. If you know about fentanyl, I would have probably only used about 100 on you, Mike, or me. Most adults would only be 100. And then you'd put on maybe 6-7 milligrams of Versed. Well, that record was 525 micrograms of fentanyl and 46 milligrams of Versed, and the SpO2 never went below 98. The blood oxygen level never went below 98. Why? Why? When I got done, there's a set of third molars, by the way. When I got done, the patient, I sat him up, took their sunglasses off, and they said, hey, wow, am I done? Yeah, you're done. It's metabolic rate. You can't measure that. Okay, you just can't. So when you have a patient come in, and I'm not trying to be derogatory in any way, censor form, if a patient is heavy set, if they are bordering on obese, that is a slow metabolic rate. You're going to metabolize your drugs slower. You have a 40-year-old walk in your office, and the guy is some kind of construction guy, and he's ripped, he's got maybe 2 pounds of fat on him. You're going to use a lot of drug on him. They're going to metabolize your anesthetic quicker too. I don't know if you guys know about the freckle-faced redhead thing. Freckle-faced redheads have an extra little cool little enzyme that you're good luck getting them sedated. When all of us sedation people know about the freckle-faced redheads. So, you know, when you have somebody that sits in your chair, they're slower moving, they're a little bit more heavy set. They might not use as much anesthetic as that guy or lady that comes in there and they're skinny and ripped and walk down the hallway like they're on a mission, even though you gave them 5 or 10 milligrams of Versed 90 minutes before. But that's kind of a whole different discussion, except it does fit what's going on here because it's in my head now. When I sit down to sedate somebody, I'm going to take all their teeth out. Who am I doing this on? Does this person have a fat? And am I thinking? I'm thinking like 1 to 3. Extremely fast metabolic rate, sort of normal, or not a very fast metabolic rate. So all that fits into my anesthesia protocol and how I go about this stuff. More questions?
All right, walking back through the study club, and I already know how I'm gonna do this later on. I'm gonna have all of you send, after we answer all these questions, any questions you want specifically answered in Dan's PowerPoint, you're gonna send to me and I'm gonna forward them to Dan. So it might be 30 questions he's gonna answer. But we're gonna touch on every single thing because I can sense that everyone's like, yes, I want to do this. But it's kind of hard to pick up from this format. So we'll make sure we get it. But let's at least touch on it now, and we'll also back it up with the other PowerPoint. So Dara's saying, can you exactly explain a step-by-step explanation of hype for the AMSA, which and why not a V2 block? You go back to the palette on that one.
A maxillary block?
Anterior AMSA. That was the anterior middle superior alveolar, wasn't it?
As opposed to a
V2.
a 5-2? Is that what they're talking about? The maxillary nerve block or the?
I'm not sure. Dara, can you explain your V2 block?
Oh yeah, he's talking about V. I'm thinking the 5th cranial nerve. Anyhow,
Yeah,
yeah.
my
So
question,
go ahead.
can you hear me?
Yeah.
I'm sorry. My question was on the AMSA, you're just doing the palette. Usually the palette is a little bit more tender for patients. So any specific things that you do to make it easier, and how much of a carpool do you place in there? Just kind of a little bit more elaborate on that, if possible, please.
I'll tell you why I wouldn't use a maxillary block is because it doesn't give you pulpal tissue. It gives you soft tissue, but not pulpal anesthesia.
We're
That'd be a good-
talking about, Dan, now he's
I'm
asking.
talking about the V2 division, full
Yeah.
block of max. That doesn't give you pulpal?
It would, but you really want to put your needle there? No,
I mean, if you, yeah, well,
no.
yeah, I know, I understand that you're talking about that, but what I wanted to figure out about this AMSA, was like, how do you approach it? And on the V2 block, I've used it once in a while, not often. I've seen also some people that are talking about using it. The way that I do it, I just do go to the greater palatine foramen, but I've seen some people doing it from the buccal. So if you have time, I would like to know about that, and if you have one versus other you prefer. But tomorrow I have a case just like this that I'm doing a full arch on the maxilla, and my question is, wanted to make sure that if you've worked fast, everything works well, but you might have some issues. Many things can go wrong, so the surgery can take longer, and you definitely on the maxilla, I want to make sure that the patient's numb, and also the bleeding stuff. So I just want to make sure what you have in there. I'd like to try this tomorrow. So how would you do this, numb this patient, for example, for a full arch of extraction, implant placement, all on X, especially if you just wanted to do this AMSA, because it looks like you right away, you're going to the palate and palate only.
Well, let me explain how I would do it. I would not do the V2 block. Where your needle needs to go for that, I think is dangerous. And I like things simple. I like protocols that work every time, that I can just sit down and go through. Everything that I do is in a protocol. I want it to be quick. I want it to be very predictable every time. And so that's why I've developed this protocol. So to numb the entire maxilla, to do what you're talking about, I think we did it once, we'll go through it. I would do a posterior superior alveolar, so a PSA, an MSA, and an ASA. That's all on the buccal, right? Then I would do a greater palatine block. Right after the greater palatine block, I would do probably a third of a carpule on the first molar and the second molar. By that time, when you want to do the anterior middle superior alveolar, the one we're looking at right here, you can put a third of a carpule there and they won't feel it because you've already done the greater palatine. And what the anterior middle superior alveolar is going to do for you is going to give you pulpal and bone anesthesia, anterior bicuspid forward. You still have to do bilateral ASAs on the labial because you want soft tissue anesthesia on the labial of the cuspids. And that you're all set in that anterior sextant, then you can do whatever you want. That's going to be numb for a long time. And I just repeated on the other side. It's simple.
Great, thank you. So in this case also, I shouldn't worry about how many carpals of Septicane I'm using.
You should never worry about how many carpals of Septicane you're going to use.
One question that I put on the
unless we're going
chat.
to go into the 30 area, you know what I mean?
I'm sorry?
Well, within reason, you're not going to use 30 carpules of.
Oh, sure.
But you know, that brings up something that we need to talk about. Some of these cases are going to go for a long period of time, and you will run out of anesthesia if you're not timing it and looking at it. So duration is helped by saturation. About challenging either the blood or the liver, you got to remember that because this stuff all has epi, it's the blood and the liver is being titrated because of the epi that's in our anesthetic, right? The reason we use the epi is to keep it in the area longer, but it's slowly going to be absorbed into the bloodstream. but the blood can handle a lot of this.
All right, Dan, so to summarize, Derek, because I get it, you got the surgery tomorrow, I'm gonna lay this out for you. The first question was when you're saying a third, we're all thinking, oh my God, there's no way I'm putting a third in right away. So obviously you're doing a few drops in the posterior, a few drops, you let that take effect so the patient's not hurting, because ours aren't sedated. I know yours are sedated, but ours, most of us on this call aren't sedated. So after it gets a little bit numb, then you go back and you're going to saturate it. And I mean, go back like a minute later or something like that, and put it in there to saturate it. Or are you trying to put in a third of a carpule in the palate at one time?
So that's the
Or-
problem with a short discussion like this is, yeah, there's little things like that that I'm leaving out. So yeah, I would put just a few drops in the greater palatine, go to the other side, a few drops of greater palatine, and you can come back a few minutes later and do all these other ones. You're not going to feel it, right?
Right.
So,
So
just like
so
what you
that's
said.
cool. So let's say then let's just map this out, because Dara's doing this tomorrow, and I hear his anxiety. 'Cause if I'm doing this surgery, I'm sitting here writing down notes saying, hell yeah, because I want to try this, see if it works. So I'm going to put me a couple drops back in the posterior, and then I'm going to start walking it forward. After a couple of minutes, I'm going to do maybe a quarter of a carpule back there in the PSA again at the first molar, second molar, and then up at the MSA. So I've got an entire carpule in one side alone of the palate, correct?
Yep.
All right. Same thing on the other side, but we obviously were doing this at the same time. We're going back and forth. So you spent 2 carpules on the palate, and you weren't sitting here waiting, just doing that. After you give those 1 second things, you flip it over to the other side, and you're doing your blocks then third molar, first molar, canine, 2/3 of the way up, and just straight up imagining you're shooting at the apices of these things. Is that correct?
That's correct.
All right, so that's your anesthetic for a full maxilla, because I'm thinking the same thing, because I'll be doing the same thing.
Yep.
Because this is, I guarantee, Dan, maybe there's 2 or 3 other guys out there out of the 30 here, maybe, that are doing this. I guarantee that 90% of us are just doing infiltration. And to us, and speaking for myself, this is cool as heck. Heck yeah, I want to see this and I want to do this
Yeah,
and
because-
see how it works.
It winds up being just a protocol that you have on your head and you just go bang, 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 bang. You don't think about it. You don't have to
Exactly.
think, okay, well, I'm gonna infiltrate over here, and what am I gonna do over here? Yeah, you get away from all
Right.
that.
Well, we got to break the first infiltration modality in our head and then enter into this new one. Dara, does that make sense?
Yes, absolutely. I have one question though. I have kind of sometimes by default have done this type of anesthetic this way, but I do have realized sometimes, especially when everything is flapped out, even the palate is flapped out, sutured away, you're, I don't know, 2.5 hours, 3 hours through the procedure, and then you go in there, you know, trying to put your last implant there or something, and the patient's jumping and they're feeling it. What is going on at that point? What's happening? And if it happens with this protocol somewhere down the road, what do I do at that point when there's really no palatal tissue? Everything is flapped away. Everything on the buccal is flapped away. What is going on where everything else is okay? They don't have any problem, but there's one spot. Usually I find it around like 8 or 9 area, or the canine, that you touch the bone and they're feeling it. What is happening there?
So
That's-
that's why you're gonna, because you're running out of anesthesia. You're running out of, you're losing your saturation because the anesthetic has been taken away and metabolized from that site. So hence, saturation volume starting off. That's the only way to keep your shoes out of that muck, is to use volume, and that's where you guys get the creeps.
Right. So
I'm telling
because
you.
I agree. How many of us out there are starting with 8 carpules in the maxilla? I am not. Maybe 4, maybe 5, maybe even 6, and certainly not in this area. I may be infiltrating the hell out of it everywhere, but I'm not hitting these specific block areas. So I'll agree with you, Dan. Dara, the other thing is, as far as your flaps go, and I get it. When we flap, Dan, to us, it's harder to hit your spots because the tissue's moving around. And you've got, especially in the buccal, not so much the palatal, but we'll touch on that also. you're thinking I'm shooting it up there, but it's not in the soft tissue. So you're still having to envision injecting. Let's say he's 2/3 the way, 3/4 the way through this, hell, 7/8 of the way through the surgery tomorrow, and it starts waking up. He goes, "Damn, I got to put another one up there by the canine, but I'm already flapped the canine, damn near up to the zygoma and all that. So it's pretty deep." You're staying in the soft tissue when you do it. You're just trying to visualize where that would be because the nerve doesn't change. It's in the soft tissue, correct?
All right, so let me answer his question and actually give him the answer. Are you gonna reflect the entire palate?
No, I only reflect 2 or 3 millimeters past the reduction, bone reduction.
Right, that's all we need. So you're just simply
Yeah.
gonna add an AMSA to get that cuspid or central or what in the front. That's the beauty of that AMSA. It is pulpal anesthesia from the second by forward.
Mhm, mhm. I will try it tomorrow for sure.
Just make sure you use enough and get it in the right spot.
I have one
Okay.
comment to add about the pulpal or the palatal injections being comfortable. I don't know if anyone on the call has had the wand by Milestone Scientific.
Oh,
Anybody got the STA or the wand device for anesthesia?
I have not had the opportunity to use it. I'll be honest with you. I tell my patients, look, I'm really sorry, but this is gonna sting like the dickens. And that's exactly what I say. And I put pressure with my mirror and I get it over with. And it's really interesting when you get all done with the surgery, like, dang, I didn't feel a thing. This is my non-sedated people. I don't sedate 100% of my patients, but they're just happy they didn't feel the dentistry itself. We haven't even talked about the mandible yet. We got to get there. But the reason I asked everybody that question in the meantime, I would like to try one of those anesthesia instruments one time though. I would. The wand, I've seen it advertised. I would like to try it once. I think it'd be
I've
cool.
used it since they came out in '97 and would never go back.
Yeah,
mean,
that's awesome. It's
everything.
fun.
And you don't need to do the drop and come back. You can go directly in. It starts numbing right away. You can put as much anesthetic as you want. It's pressure sensing. So you can drop your quarter carpal, you just wait for it to drop in and patients don't feel the palatal.
That's awesome. That's really awesome. I'm gonna get one tomorrow.
It is great.
Where was I going? I forgot where I was going.
You're going to the mandible.
Okay. One of the first things I mentioned to everybody is, I know all of you have had a patient say, "Ooh, I can feel that." If your patient ever says that, they'll remember that forever. You need to anesthetize so that they never feel anything that you do. The first time you hit that dentin and they're not anesthetized, they'll remember that forever. And you might say, if you're one of those doctors that says, it's okay, we're almost done. I've had that done to me. And if you do that to a patient, they're probably not going to come back. People don't like that. I didn't like it. I had endo on number 9 finished without anesthesia because the doctor said that it was necessary. Anyhow, let's talk about mandible. Does anybody ever have any trouble with number 30 and number 19? Getting those 100% anesthetized? Be honest.
Never, Dan, in 35 years.
Uh-huh.
Oh, you said be honest. I'm sorry.
Yeah, so my protocol for anything on the mandible is 2 carpules of articaine at the site for a Gaugates. 2. Then I use a little bit for a long buccal, like a 1 carpule. I use like a half, a little bit farther distally to pick up the lingual nerve and the long buccal. And I'll wait. And then I always do, if I'm working on that first molar, I always do a buccal and a lingual infiltration. Even though it's only like 17 to 20% of the patients will have innervation from the mylohyoid to that tooth. That's a 1 in 5 chance my patient's going to go, ah. I'm not doing that. I'm anesthetizing that first molar from the buccal and the lingual. And there's outliers too. Sometimes occasionally it'll happen on bicuspid, but it's that mitohyoid thing just wandering around. So that's the way I like to do it, because I never, ever want my patient ever to say, I can feel that. There's some outliers. I mean, in my career, I have one guy, Randy, not going to say his last name, of course. Randy can stay anesthetized for 15 minutes. That's it. But Randy's my age. He weighs 150 pounds like me, and he walks down the hall about 10 miles an hour. Metabolic rate. So that's my protocol for the mandible. Questions?
Sorry. Yeah. Do you have a photo of this on the mandible for the, so we can show this? Same
Yeah.
as we did the maxilla?
The Gal Gates?
Yes.
I do. The Gal Gates is creepy. Because you have to go up at the head of the condyle. And the way to do it is the plane that your needle will be at is actually at the height of the tuberosity, not at the height of the occlusion of the maxilla. You'll be way high, way posterior. Like Malamud says in his book, the higher and the more posterior, the better off you are.
Don't they have to open a certain width too? They're open wider or something like that?
Thank you, yes. If they do not open wide enough, the condyle will not present itself to you like it needs to. And so the condyle will be back farther, and it'll creep you out even more because it's so far back there. You have to make sure they open really wide. So that's where
All
it
right.
goes.
Here's a picture from the book that he found. That's kind of looking from the top down. We need to look from this. Is there a shot from the side also? Okay.
Looking for the book.
Can you see that, Dan?
Yep. Let me hunt for that other photo. I believe I do have it.
So we all think mandibular block.
The
Talk
IA.
about it, right? Talk about it relative to that, because that's what we're used to. And if you Google this, there's about 800 pictures on this. Carlos has just Googled it and he's showing me it. Well, hell, let's do it on here.
I could put this up here.
Okay. Carlos is about to throw his up there. There's about 50 different pictures here of Gal Gates blocks going in. It's dental porn at its best.
I have patients sent to me from multiple dentists in the area because they can't get their patients anesthetized in the mandible. And so they want me to sedate them.
This one here. This one here.
So I sedate them and I do a Gal Gates on them, and they don't have any issues at all.
Go back to that other one. Can you just, let me just slide this out of the way.
They can.
All right. Okay, you can see this. So you got infield Gal Gates and VA, whatever that is, on that one slide. Here, drop this down a little bit more.
Yeah, there's an ankylosing. That's a weirdo when they can't open. That's kind of valuable too, though.
No, this one here. I want this one. Slide down so I can see this. All right, Dan, we're looking at this one on the.
That's it. That's all there is.
Oh,
Yeah.
now don't go to the site. The site always has too many words and all that. Just stand there. All right, using this picture to the side where it's got the blue box, or if you see a better one, shoot with that. I don't care. But this one at least shows them right inferior alveolar right next to a Gal Gates, so you can look at that and describe the difference of that. Does that work for you?
Yeah, I like the one actually way over on the left better because it's higher.
With the red circle?
Yep. Yep.
Okay, let's talk about that one then.
Yeah, so
There you go.
You really have to bend the needle too, about halfway down. You don't bend it at the hub ever. Just take your thumb and you just bend it just a little bit, maybe about 30 degrees halfway down, and with the bevel away from you. And you go literally at the height of the tuberosity and do kind of the same thing as you would normally do with your angle with your IA, except just go up a lot farther. It looks quite a bit higher.
sounds funny, but do you do a block first to get it numb for this? You just go straight in with the Gal Gates? I mean, I know you do, but how about us?
No, when my sedated patients, yes, I go straight in and do it. However, there's this cute little anesthetic called Prilocaine that when my patients are not sedated, I warm that up. It's the least acidic of all the anesthetics. I warm it up in a carpial warmer because they can feel 70-degree anesthetic being injected in their tissues. I warm it up and I go in very, very, very slow. And I just very, very slowly give a half a carpial of the Prilocaine. They barely, and that's with a 30 gauge needle. So I'm not necessarily going all the way to bone here with that 30 gauge Prilocaine, but it takes care of following up with this. When I follow up with this, they don't feel it. I do that with actually all my injections on a patient that's awake.
You use Prilocaine first on all these blocks we're talking about. You warm up, and if you don't have a warmer, which I have warmers in all the rooms, but heck, a cup of warm water.
Yeah, exactly.
You
Yeah.
drop it in there, you warm it up, and you're doing, let's say this, Darius is doing his full mouth. Let's say he's doing upper and lower tomorrow. You're gonna have a couple of Prilocaines there. How many Prilocaines can we use?
So that's the one that you got to be careful of, but you're not going to
Right.
use that many. You're going to use like a third of a carpial on these injections. Okay. So you're going to use a couple of carpials.
All right, so a couple carpals of Prilo in all these areas to get it started, let the patient get numb, then come back with Articaine and over the third molar, over the first molar, over the canine, posterior, superior, working way forward into the palate now, second, first molar, and then forward of that a little bit more to get the AMSA. And then you're coming over here after you've given a Prilocaine up in this general area at about half depth. And then you're going to go to full depth and you're going to put the Gal Gates in with Articaine. Is that right?
Yeah, sort of. There's so much that's being left out of that. I need to write a book, I guess. I would
You're
start
going
off-
to. You're
I
going
was-
to write a small PowerPoint book for me, but go
Okay.
ahead.
All right. I would start off with the PSAs first. Do the posterior fillers on each side, because by the time you get back to the first side that you start on, the
Yeah.
MSA is going to have some anesthesia to it, and then
Okay.
go back and do the MSA on the other side. By the time you come back and then do the ASA, it's already numb.
Got it.
It depends what I'm doing. I won't always use the Prilocaine if I'm doing a case like that, if they're awake. I'll go after that posterior superior alveolar first. Because when I used to do anesthesia for, I don't do the hygienists do it now, but just to do scaling root plane on the top, you just see an MSA and an ASA. So I do the MSA on both sides, and by the time it came around to do the ASA, they wouldn't feel it.
All right. To be clear, your hygienist can numb in your area, correct?
Correct.
All right. And you've taught them these techniques. So when we're sitting here, like as Dennis going, man, I don't know if I can do that. You've taught your hygienists how to do this. They're all doing blocks.
Exactly.
All right.
So
Um,
they've gotten so good that if I'm doing like an apicoectomy where we know you got to be a flap on one tooth on both sides of the tooth you're working on, they know what to do. We
Dan,
don't,
when's your next full mouth sedation case you got coming up? You probably, is this a fairly regular occurrence?
Yeah, I never look at my schedule ahead of time. I look at it
Neither
in the
do I. Yeah. All right.
So
I want you to look tomorrow because I want to video this also. I want to give them as much information as I can to the team here because I know that there's a million questions out here and we're going, hey, I want to see this, I want to see this. And we're not going to answer these all in the next 11 or 12 or 20, 30 minutes even. So you and I are going to put together, when I say you and I mean you, by the way, a PowerPoint, and I'll help you and coach you through this and a video and all this. And when we're down in public, because we're both going down together, we'll hash this together and we'll get this out. I mean, you've lived your whole career without this. Another week or so to make sure and do this right, we'll have time to get that perfect then. How's that sound to you, Dan?
I think I found the book.
Sure, Mike.
What else do we have to do? I mean, you slacker. I mean, you've broached this subject. You've got them on the edge of their seat. We got to bring them home, and this is how we work in the family. So we're going to have to get this thing perfect. And again, I keep saying we, but I keep meaning you. And we're gonna get this perfect so that we can give it to them, because I know they're on the edge of their seat saying, I want to do something, because this is cool as shit, Dan. This is fantastic. If speaking for a full mouth person who does maxillus, and it's always beat the clock, because I don't anesthetize my patients. I like them to be able to stand up and this, that. There's a lot of things that I like about it, even if I could do it and I'm not trained in it. But
It's a
we
different
got,
world.
yeah, I bet it is. And
It's
if
a
I
different
can
world.
talk Isaac into doing that next, he's a little busy, but if I can talk him into doing that next, then I'll use it in my world. But until then, like so many people on this call right now, we gotta learn how to do this. Even something like the Gal Gates, your first times, like you say, it's freaking you out a little bit because it's a little different, but it's not that different. I bet once you do it.
It's not. You got to use the tip of your needle as a probe. If you're not on bone, back up, go a little lower, a little farther forward.
You're just walking up the ramus.
Yep.
Yep. And if you got a little Prilocate in there first, and it's not killing the patient, you're not
Right.
sitting there going, oh, 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 and you know, have be a nightmare situation that we all hate.
There's one more thing with the mandible. We all should use our thumb and our middle finger to grasp the mandible and not use some type of a retractor,
Yeah, I agree. Yep.
because you cannot, you have to feel that the anterior ridge, what that feels like, what that curve feels like, and you have to feel that little curve in the back for when it's just gives you those landmarks for to have some idea where you're going. But there's one other thing. Sometimes you wrap your hand around this guy's walks in your office and he has no neck. This guy's head is as big as a bowling ball, and his shoulders. I mean, you know he's not going to fit in your CBCT. It's going to just ding him up, right? You put your hand in there to grab a hold of this guy's mandible. It's like
Yeah.
3 inches wide. When people that like that show up, you really think you're going to get him numb with 1 or 2 carpules of anesthesia up there? You have no idea where that lingula is to anesthetize that nerve. You might think just put 3 in there. You get people in like that, put 3 up high. Put 3 up high. Just saturate that thing.
Yeah, even that paradigm shift for those of you who are listening, sitting here thinking, "Oh, I only put one in. I only put the second one in when I really need it." And Dan's saying, "Screw it. If you're unsure, then you need it. Drop in a
Drop in.
second, drop in a third, stop it. Let's say a hard limit of 21, Dan. That's how is that just like blackjack, okay? 21 carpules, should that be our hard limit for now?
I mean, it's not that much because of the mandible, right? But the whole idea we have to get in our heads is the saturation thing. Saturate that son of a gun. Hence the first molar in the mandible. Saturate, get the block, saturate it from the lingual, and the lingual, you got to go down there a little bit, folks, and blow a bubble on that attached gingiva. Same thing on the buccal. You have to go down to the angle of the mandible. That's where that mylohyoid is wrapping in from the lingual. Like I said, there's so many things rattling around my head right now.
All right, we're gonna rattle around on this thing. We're gonna take photos with your staff. We're gonna do it down there. I've got a photographer in there, and I'm gonna use, instead of anesthetic, I'm gonna use maybe the needle with the cap on it, or we'll use
No,
cotton tip applicators.
we're putting you in the chair, and you're also all on in on this. You can be the guy. A little couple pokes won't bother you at all. You're a tough guy. Come on.
I'm bringing Carlos down for that. He's paid for this. He's young. He's healthy. I mean, you can shoot him up all you want, as far as I'm concerned. All right. In the few minutes we have left, is there anything else that you want to tell us? Because I was going to ask for some cases for some other folks too.
Unless somebody's got a question, I'm good. So many of this, I'm spurting all this stuff out. The Gal Gates is technique sensitive. It just is. The other ones are pretty dang easy, but the Gal Gates is technique sensitive. You can't be a chicken. You gotta get back there and start poking on some bone. It's the only way you're gonna get it. That's why the students that you've allowed me to work with, I showed all those guys so that they had an opportunity to do one themselves.
Well, the cool thing is we can video this, and we can have you talking over this. We can put the video on the portal. We can put the photos first of the PowerPoint. And if we give all that, that's going to cover about 90% of this and make everyone a lot more comfortable than they are right now. Because right now they're thinking, sort of understood it, get it, maybe. We're gonna get you further home than that. I just don't know that we can get it in this format in this night. So let me go and ask a couple, go through the chat thing. We're gonna work our way backwards here.
Yes, you got, no, you're good.
Is there a better way to upsize this thing so I can not look at Dan's face anymore? No offense. I want to see the size of the chat bigger. Okay, so you use the 3 or 4 carpals on the lower always. Dan, these are questions for you. Do you use 3 to 4 carpals on the lower always?
I would say 3 is the standard. I would do 2 ASAs. I'm sorry, 2 Gao gates. Always, 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 always. 1 for a long buccal, not like a quarter of 1 for a long buccal, quarter of 1 for the lingual nerve, and the rest for that first molar.
Very good. Is a shorty implant appropriate for locators? Hell yeah. If that's the only bone, that's one of the great applications back there. Do you want just locators at the canines, or do you want to put some shorties in the back that, because they won't run into the IAN and they'll stay above, and they can even broach the soft tissue just a little bit. Yes, I absolutely, that's one of the uses for them. Any comment about buffering anesthetic? I don't even know what the hell that is. There's been a couple questions out here because I never buffered an anesthetic in my life. Dan, what is that?
Yeah, sodium bicarbonate in the anesthetic. I've been anesthetized in other parts of my body with that stuff before, stupid boy stuff. And it is remarkably way more comfortable than just straight up articaine or lidocaine. But they're trying to formulate it for us. I think you can buy it in bulk, but it does work. It's too clumsy for us right now.
Okay.
It does
Explain
work.
to me, explain to those who don't understand, what is this? What do you mean sodium bicarbonate? You're injecting, you're sucking something up into your syringe and adding it to it or something? What's going on?
Yeah, because anesthetic's pretty acidic, right? It doesn't have to be as acidic as it is to work, but it'll anesthetize that nerve in like twice the speed, and it'll be almost painless.
If it's buffered.
Yep.
How do you buffer it? Explain that situation to me.
Using the sodium bicarb in this, sucking it up into the syringe. And I don't remember
Okay.
what the formula is. What percentage of sodium bicarb is and all that, when what to what. You know, I don't know how much to say to that.
Okay, that sounds really vague and gray. We'll add that to the list, buffering. I sort of sucked something up and I sort of shot it in. I can see me in a court case discussing this.
I've never done it. That's why. Okay.
Okay, fair enough. X-tip is my hero. Okay, Neil wants different protocols on the slides for maxillary and mandible, what's working, when's not working. Something about the anesthesia gods you must sacrifice to it. Again, Carlos is available.
I'm not talking to Neil this week.
Okay, Neil's not going to be there. You're safe. Well, then you can't talk to him, but he won't be there.
In that case,
any danger? Yeah, you can talk all you want then. Any danger of using it in a PDL technique here with, I'm guessing Septicaine is a question there.
Why are you using the PDL? Did you not get your block right?
All right, I think these are all things that, as if I'm hearing this right, if we're blocking correctly, all this other crap that we've been doing to put it in there because we haven't been using enough anesthetic, we haven't been doing this. You're going to teach us how to avoid that, and PDLs and little things like that are pretty much out the window. Yeah,
let me not be a smart aleck about the PDL. The PDL, I don't like that because the amount of pressure that you put it with the anesthetic in that can cause pulpal ischemia. It's a good way to kill a nerve, especially if that nerve is 80% healthy, 70% healthy.
Okay, I know I got new messages at the end. I'm going to go up through this chain first and then work my way back down to the beginning. All right, so buffering asked again, Septicaine, do you use, we didn't talk about bleeding much, Dan. What do you do for bleeding?
Oh, you're right, we didn't. 1 to 50 Lido. And then you're going to go right where your incisions are going to be, and at the base of where your flap is going to be, sometimes right in the flap. So sometimes we'll reflect the flap and we'll have one particular place in the flap that it's bleeding. I'll squirt just a little bit in there.
Do you put it preemptively before you start the flap or after?
Absolutely. Absolutely. preemptively, absolutely.
All right, so
preemptively.
so for all of you, you've mapped out the flap, because you're always mapping out your flap. You're thinking where you're gonna do it. And the great thing is this thing spreads out, so it's gonna, you don't have to be like within a millimeter of this, it's gonna spread out. So you're in a 1 to 50 along your flap die, taking just maybe a carpule per incision or something and just working down there, because you're only using that just locally, correct?
Yeah, I don't use that much with it. I'm being really, really precise about where I'm putting that, right actually in the incision line. And I'm worried about the ischemia. I mean, we're reflecting flaps and we want blood supply there and all that. So I'll
Right.
put some right in the incision line, right on the crest, a little bit on that attached gingiva on the lingual, where I'm going to reflect
Mhm.
the flap. And then on the buccal, at the base of the flap, where I'm going to reflect down to, I'll try to go actually superior to that, where the base of
So
my flap would be.
in a normal flap, 3-4 teeth long, you're not using more than a carpule. You're using half a
Correct.
carpule, 3/4 drops
Correct.
in there in each one of these. Okay, cool. Good to know. Necrosis, no, we don't worry about that. Send out Arctic in the Paladin. We already discussed that. We want to find a digital version of the book. We're going to take our favorite parts of the book and we're going to add them to the PowerPoint here. We're going to,
I found it.
and Carlos has a digital version of the book and is sending it out to the group.
Are we
Yes.
legal?
There will be a link.
There'll be a link
Yeah.
Can we-
for
the.
Can we do
for the
this legally?
PDF.
Carlos again is the one going to jail, Dan. I really don't care. He's
Okay.
expendable. Oh
All right.
wait, his headset's not on. Hold on.
Copyright
Uh,
infringement.
The link is so you guys can buy it or get it, or how's that work?
Yeah.
Yeah, what does that mean? Oh, that was a shady answer. All right, you get back to me on that one. Like to, you know, if you, the link is if you want to buy the book or get it, or, all right, flapless case, how do you decide what size tissue punch? You think about the size of the implant, you go a little bit bigger. So if I'm putting in a 5, I'm going to go 6. I want to go a little bit bigger. I think more about the healing abutment size. You're going to put a bigger healing abutment on there because the healing abutment is going to be what touches the sides. And if not, that gingiva is going to grow in an hour anyways, so it doesn't matter. But so I go a little bit bigger, and I've got from Salvin 4, 5, 6, 7 all in one block. So I have every size tissue punch I want.
Also, you want to see where the implant is in relationship to the crest of the bone.
Yes, it's nice. So you want to go a little larger, but it's not like I'm doing a 3-5 and I put a 7 in there. That's not necessary. At least it's not for me. Hi, Dan. Good to see you virtually. All right, we're going back down to the bottom now because I've had questions added since we started. So Dan, call me anytime. Dan, I think gave that a hard no. That's Neil Patel telling you that. Some people mix it themselves on farm. And farm makes one. So they're talking about buffering here. I injected in the carpule of everything. All right, you guys can give me your home recipes when you send the emails in, because Dan said he's not a buffering expert. So one of you who buffers already will have to give that to me, and I'll give it to the group.
Yeah, I'd like to know that too.
Yeah, well, you're going to, because you're going to get all these. You're going to have about 500 emails and a whole book and PowerPoints and video. This should only take you about a week, Dan.
I'm riding my dirt bike this weekend, Mike.
That's fine. Once you get down there, it's all work, baby. All right. Any cases we have to go over here? Because we've done this. We're up to 9:04. That's fine. I don't mind going over it. They don't either. Heck, we're all learning. If you don't, just drop out. Who has a case to go over? Because there were some people that had some cases to go over. Go ahead and activate your microphone and just jump in or do whatever.
I got one.
Who's that?
Jared.
All right, very good. Jared, do you know how to get on here with share screen and all that?
No, I don't.
Do we have to end ours? What do we have to do? No.
Jared,
He's going to walk you through it.
Are you on your computer or are you on a phone?
Computer,
I'm on a
phone.
computer.
Okay. So once you open up Zoom on your menu bar down at the bottom, there will be one green option to share your screen.
Okay.
You just want to hit that and then double click on what you want to share.
Can you see that?
Yes, sir.
Very good.
All right. So this one, I think that I talked to Dr. Worley about before. It kind of goes into like patient selection and also kind of what to do when things kind of go wrong. So bear with me on this. So I had this guy came into my practice. He's a kind of like a gangster dude, and he got pistol whipped. and it took out his front tooth. Yeah. And so this guy came in, and so I took out number 9, and then I grafted it, and it came back 6 months later to do the implant. Um, so let me see if I can click on this here. So this is how I planned it. I was going to get a 13 millimeter implant in there. He has a ton of bone, and it was pretty dense bone too. What I didn't realize, he also has a ton of attached tissue there. So I went in, did my guide pin shot, got down to 7 millimeters, and continued to drill a little bit. The only issue is the guy was high, like really, really high, and and he was like tweaking pretty much. So that's where my patient selection kind of went south. So
Now hold on. Is this an anesthetic technique you're using that Dan's unfamiliar with?
it must be, yeah, he was, I don't know what he was doing, but he was in another world there for a while.
He needed just a little bit more, just a little bit more is
He's
what.
sitting
Yeah.
high on marijuana.
Yeah, oh yeah, he's baked. But anyways, so I got down 11.5 millimeters down, and he started freaking out about the vibrations of the implant, and he told me to stop, and he wants me to just put the implant in. He was done. So this is about 15 minutes into the procedure, and so I was like, okay, fine. Well, I'm 11.5 down, and I'll just put in a 10 millimeter 3.5 by 10. Which is way too short, as Dr. Worley shows. You can see the roots of the adjacent teeth. They're longer than the implant. So that's the first kind of screw up that I had. The second screw up was aesthetics. So I got good ISQs on both sides of the implant, buccal and lingual, but the tissue was just huge. So you can see this is actually the day of suture with the healing cap in. So the tissue's kind of eating the healing cap, but he was out, and luckily we got these photos before he dipped out. So I was talking to Dr. Worley about how I'd manage this, because I didn't have a custom healing abutment. So I was going to ask you guys what you would do after this. He's already gone through 46 months of healing, and he's wanting his tooth in. And, like I said, patient selection, the gangster wants his tooth. So the quickest way I recommend.
Let me ask you a couple of questions here.
Uh-huh.
What's in here now? Is this a tall cover screw or something, or why don't we see anything here? What's underneath there?
Yeah, so that's the cover screw underneath.
Okay, tall cover screw. What's the size of this? We talking about the 2.6 Megagen one?
Yes.
Because that looks like a healing abutment. Actually, it looks like a 4x3 or something.
Oh yeah,
Which
sorry. This is a healing, but yeah, this is a healing abutment on there.
And yet it's still covered by the tissue, which, by the way, I use those sometimes for just this purpose. So there's nothing wrong with that. That's fine. I just want to know what's in there. All right, cool.
Mhm.
So you got that in there. I'd say you do this like the case that I just showed you with that I did using the Corey Glenn technique, where you slice it open and you take a quick impression and tell your lab, because you can't mill all this stuff yourself, right? You don't have a mill in the
Right.
office? Okay,
No, I
cool.
don't.
Then get your local lab, whoever, to make you a PMMA temp on a tie base restoration as fast as possible, and slip it in there and let it heal. And just tell this guy, hey, this is how it works, man. It's a 2-step technique, because he'll bust your balls now. When it turns out like shit, he'll bust your balls and he'll sue you. So
Yeah.
you can't let the idiot drive the car. So you're going to have to just tell him this is how it is. Then you can train the tissue in there nicely, and have some wiggle room to be able to adjust and do this, that. And then it's just, you take a final restoration. Your other problem from looking at this is it's a little bit straight into the ridge. I would have liked the apex of this implant a little bit more to the facial, and coming out more of the cingulum area from the looks of it. But it's still very, very workable. I'm just saying it would have been easier, because then you've made it screw retained, which I like, which I still do screw menable up in the anterior. But given the guy you're dealing with here, I'd make the temporary, put it in there, and that'll also tell you where your screw access hole is going to be. And some of these, you can even get an angled a screw channel in there from some of your labs that you might be able to get out the lingual then by just by changing a few degrees.
Okay. I'll definitely request that.
Anyone else got any ideas here? All right, that's what I'd run with.
Okay. Yeah,
I
thank you.
think your implant's going to work. It's short because we're nerdy dentists. It's not going to fail because it's a 10 and not an 11.5. That's not going to happen. The size of it, if this guy is a real grinder and all that stuff, that could be a problem. Breaking it in that it would have been nice to get it up to a 4, but I understand why you're doing what you're doing here. Just because it would have got the core size bigger. It has nothing with the width. It's that the 3.5's got a 2.8 and the 4's got a 3.3. That would have been nice to get that up there, but you know, you got what you got. You're going to get it in. It's going to last for a good long time, and he's going to move and do something else. That's next time it'll be a prison dentist working on him. Don't worry about it.
Yeah. All right. Thank you, guys.
Very nice. Thank you. Is there anyone else? Because I think I talked to one other person about presenting today, at least one. All right.
We left a whole anterior mandible off in the horizon.
You mean you haven't numbed up my anterior mandible yet?
No, I mean, you can infiltrate bicuspid forward, right, with articaine, incisive block.
All right. Well, I'm not going anywhere. Anyone can drop out whenever they want. I still want to hear this. Keep going.
Okay,
One
so if you're
second,
gonna
quick-
work on
let's just-
mandibular
real
anterior,
quick.
mandibular bicuspids, if you're doing restorations only, including crown preps, you can infiltrate with articaine and it will work like crazy. You won't get away with this with lidocaine, but if you anesthetize at the apices and then do similarly on the lingual, and I'm talking a full carpula on the buccal and a half a carpula on the lingual, you can do operative procedures on bicuspid anteriorly with articaine. The only time I would not is if you're extracting the tooth or doing endo. It will not go through all of that infected stuff down there because the chemicals are all upside down. The incisive block is basically where the mental foramen is. It goes anteriorly through the bone. It provides anesthesia to cuspid anteriorly. Works really good. We use it all the time, like 100% of the time, but not when it's infected.
Do you aim at the mental foramen in effect, or are you coming anterior to that?
Aim at the mental foramen, use a whole carpule, and then push on it. Because the incisive canal technically is inferior in the mental foramen. So if you push on it, you'll get some pressure and hopefully push it anteriorly. But if I'm doing any kind of anterior restorations, I do not
Pull me up.
I do not count on the incisive block doing everything for me. It's just too not predictable enough. So
And to be clear, this is if you're just working mental foramen forward, basically, and not you didn't do a gout gates already, didn't do all this stuff. This is just, hey, if you're working on the front 6, 7, 8 teeth, depending on which one where the mental foramen is, bilaterally, I'm talking about 6, 7, 8. Then you're just doing mental blocks for those.
Yeah, it works really good when you're doing something like you're working on one side of the mandible and you're going to do a block for that because you're working on a molar, doing an endo or a crown or whatever. But you're going to swing around the other side. Let's say you're working on number 19, you're going to block that side, but you have to do a restoration over on 27.
Got it.
You can do an
Yeah.
incisive.
That way, their whole the tongue's not numb both sides
Right,
and all that stuff. Yeah.
Exactly.
With the mental foramen, just for clarity for myself, I'm just aiming at it. I'm not quite sure what the pushing hard is. I'm trying to push through the bone or something.
No. You're using your thumb and push on that anesthetic.
Oh, okay, that's what you mean. Yeah.
Yeah.
Okay.
Yeah, massage it forward. Try to push it back into the mental foramen or into the bone.
Okay.
I've tried it both ways. There's no question it's better if you massage it.
Okay.
You patients go,
I've
"Oh,
seen
okay."
some people using guides where they figure out where the nerve is, and they've actually got anesthesia guides built into their guides now, where they're slipping the needle through the guide in that exact location to slip it into the foramens. Have you
Okay.
seen her? Have you seen her done that?
No, I'm not in the habit of putting my needle inside of foramens.
Okay, so you're just trying to get around there.
Yeah,
That
um,
works for me.
mess up one of those one day and, patients back
Mhm.
3, 4, 5, 6 months, every other week. My lip is still numb.
Mhm.
Have I
All
done it?
right.
Of course I have.
Yep. That works for me. Is there anything else we're missing, Dan?
Oh, something will come up, but you're gonna hammer me all next week about it, so.
And we're gonna put this together. This is going to be on the portal in maybe 2 weeks because we got the course. We'll be doing this and that, maybe even 3 weeks max. But we're getting this done, and I'll get this up there because I think this is too important to leave off. And then we might even revisit this at the next study club. Say, hey, everyone's got a question, has to watch the PowerPoint and all that first. And then if you have a question, you can either email it or bring it up at the study club and we can discuss it then. If you discussed gout gates, you've shown pictures, you've done this, and someone still says, man, I don't get it. So I bounce it off the eyeball and I hit into the condyle. What am I supposed to do? Whatever.
We can talk
All
about
right.
outliers then too, because this will give you tools to get those 1 out of 1,000 patients where they're just not getting none the normal way. You get another way to think about it.
All right. So this is going to be to be continued. I'm going to have a little follow up with Dan next time also. And between now and then, we will get that PowerPoint put up with the photos, with this, with video, with whatever we can make up to get this as exact as possible. So that none of us has to actually read an entire book because we're all too damn lazy. Let's be honest. Plus, in all seriousness, there's reading a book and then there's talking to a guy that's been doing this for 25 years. We kind of like the wet finger, part of this. Let's see. Someone's asking here, how do you anesthetize lower anterior lingually? So what do you do on the lingual there? Just into the lingual?
No, you're gonna go into the attached gingiva and you're gonna blow a bubble. You're gonna go imagine in your head where the apices is. You're gonna slip your needle because that tissue is so thin. You have to slip your needle in from the side, sort of. You have to go almost parallel to the tissue to slip it in, and then blow a bubble. Blow a bubble. That sounds weird, but yeah, you're
No, I
gonna
get it. Yeah. We all do that.
yeah,
I'm blowing a bubble.
you're gonna
Yeah.
put a bubble anesthesia in there, like a third of a carpule at the apices. And that's, by the way, the cortical plate on the lingual is much, much, much thinner than the cortical plate on the buccal.
Okay.
It works good. Not on
Carlos put
access
it.
people.
Okay, Carlos put a note in here, the link to keep it lingual on how to buy the book. So that link is in there.
All these pictures that we showed you, I think, came out of that book.
Yeah, I believe he went there for that. All righty. Anything else? Any other questions before we leave this for the evening?
I'm good.
All right. Dan, this was very good. We'll get the technology working better for us next time. And and like I said, we'll touch on this next time to make sure that we get this, because this is one of the better topics that we've had, because this is something that the rest of us are running into routinely. I know I am, especially as we're all going into bigger cases. And even if you're just doing singles right now, you're all growing up to bigger cases, and it's not an issue now. It's going to be an issue later. Hell, if nothing else, full mouth extractions for a denture case.
Yeah, exactly.
All right, very good. Thank you, guys. It's a pleasure as always. Thank you, Dan, for putting your time and effort into this. Sorry that I'm going to do what I'm going to do to you coming forward.
You're not sorry.
No, not at all. But I wanted to say that to make sense. Thank you, Layden.
Bye, everyone.
Bye, guys.
See you soon.
Yep.